An 87-year-old woman presented to the emergency room with leg pain. While being evaluated, she suddenly went into pulmonary edema, congestion of fluid in the lungs, and required mechanical ventilation, a respirator. The attending physician informed the family that she was critically ill and might die at any time. 2 of 3 daughters, we'll call them D1 and D2, her first name was not R2, wanted everything done to prolong life, including intubation, ventilation, and dialysis if necessary. The physicians complied with the family's wishes. The patient had not executed any written advance directives. However, the youngest daughter, D3, objected to the initiation of life support. She reported a conversation following her mother's prior cardiac arrest, the same situation 3 to 4 years ago, in which the mother had afterwards stated that she would never want to go through that again if she had the choice. The patient was admitted to ICU. Myocardial infarction, a heart attack, was found to be the cause of her deterioration. She developed congestive heart failure and recurrent ventricular tachycardia, requiring cardioversion or defibrillation, an electrical shock to either reset or restart the heartbeat, several times in the early days of her course. She was in ICU for a month, unable to come off the ventilator because of the frequent episodes of pulmonary congestion due to heart failure. During this time, she also developed paralysis of her right side due to a stroke. A nasogastric feeding tube was placed. On day 24, the resident physician wrote, quote, "Patient's family has decided to stop heroic measures. We'll discuss with attending." 2 days later, the attending wrote, "I discussed the situation with D2. She wishes aggressive medical intervention continued." On day 33, with the patient now on the medical floor, still on the ventilator, the attending wrote, "Nursing staff tells me family still anticipates patient improvement and recovery. As per my conversation with family, we'll continue aggressive care." That same day, D1 and D2 met with a social worker who advised that they ask for a DNR order and consider looking for a doctor at their local hospital who might be willing to withdraw care. The next day, the attending wrote, met with D1 and D2 and spouses. They now say they want the ventilator turned off abruptly so their mother will die gradually. Note that 2 days ago, they were talking that they were positive patient would recover and be home in 3 weeks. I told family that they have changed their minds repeatedly throughout hospitalization, and I am not convinced that they unanimously and honestly want to withdraw life support. D2 responded, "She knows patient is a fighter. She does not want to die. She would want the machines continued." I said I felt obligated to continue life support. On day 35, the attending wrote, "Patient awake. D2 now in room. Tells me patient fully alert and communicates via eye movements. She states patient has indicated anticipating full recovery and returning home. D2 is looking for nursing home, though she still wants me to contact other hospital so the ventilator can be turned off." On the next day, the social worker described D2 as extremely upset. D2 wants patient weaned and is willing to accept mother's death. Family has visited long-term ventilator care facilities. Social worker has contacted county senior legal assistants to act as an agent for the patient and write a living will if the patient can communicate in some way. At this point, the family asked for a consultation from a geriatric doctor who would, quote, "be willing to turn off a respirator." D2 told the consultant, quote, "We're in agreement that mother should rest and go to God." D2 indicated that she had initially wanted to do everything if there was hope of recovery, but, quote, "now I feel that is not going to happen." D1 also expressed her great turmoil and sense of responsibility for the course of events. She wanted mother kept comfortable and allowed to die in peace. D3 reiterated her original opinion and described her difficulty watching mother go through the last 6 weeks. The fourth sibling, a very ill son, was consulted by phone and concurred with his sisters. The consultant saw the patient and suggested the following plan, which I will not go into detail. You can look at. Before I jump into the paper, an interesting verse out of Jesus' post-resurrection encounter with Peter, and it has to do with Peter's martyrdom. I beg no contest to the theologians who will criticize my hermeneutics for applying this to other end-of-life situations. But in some ways, terminal care in intensive care can become medical martyrdom. And I think when you read this, there are some very telling truths. I tell you the truth, Peter, when you were younger, you dressed yourself and went where you wanted. But when you are old, you will stretch out your hands, and someone else will dress you and lead you where you do not want to go. Jesus said this to indicate the kind of death by which Peter would glorify God. Older patients, no longer able to care for themselves, are sometimes taken where they do not want to go. And indeed, these sometimes aggressive intervention and life at all costs approach, in which intensive care is continued to extremes, ends up with, indeed, the patient appearing to be martyred with the left arm out, hooked up to the Swan-Ganz catheter, the right arm hooked up to the dialysis machine, and there they are on the ICU bed. The case we have just presented illustrates one of many variations on the theme of end-of-life dilemmas. Many factors contribute to such crises. One, advances in medical technology, inherent uncertainty in medical prognosis, reluctance of physicians to withdraw aggressive life support for fear of litigation, ambivalence of patients and families, and finally, some physicians and patients honestly hold moral convictions that human life must be sustained at all costs and by all available means. The technological imperative. Advanced directives have been developed as an attempt to provide some opportunity for patient input to the medical care decision process. The term living will was first used in 1969 to describe an early living will. 86% of patients or persons surveyed are interested in having a living will, and I apologize for taking a used advanced directive, but this is a living will, and it was the earliest of the commonly used advanced directives now. Now, despite an interest rate of 81 to 86% in discussing these with their physicians, only 11% of people surveyed had actually talked with their physicians about a living will. Though it is an important first step in advanced directives, it is very limited in its usefulness because of general language subject to widely varying interpretations. You'll see, excuse me for walking away, I know it's hard to follow visually here, but this is a conditional, and here, of course, is the antecedent, if I have any incurable disease, illness, etc. Then the consequence is an imperative. I direct such procedures which would only prolong dying be withheld or withdrawn. And obviously, the conditions used in the antecedent are quite nebulous. Does imminent death mean a week, a month, 6 months? Likewise, the extensional definition of life-sustaining procedures is left up to the reader. Does it mean only mechanical ventilation and CPR, or could it include antibiotics, blood transfusions, or even enterally delivered feedings? While the desire expressed in the living will is consistent with the general feeling of many people, the document does not provide specific guidance for highly individualized contingencies of end-of-life dilemmas. Perhaps if our patient had had one, the physician might have felt a little easier, but the document does not directly address, because of lack of specificity, the situation that our patient was in. Such difficulties make it appropriate to consider the second generation advanced directive, as I call them, the durable power or healthcare proxy. And that is the state of Illinois form. The durable power addresses the problem of identifying a properly authorized, legal, and sole surrogate decision maker in the face of incapacitating illness. The patient selects another person as an agent. Studies presenting patients and their agents with hypothetical choices, however, have found discrepancies ranging from 24 to 50% for individual scenarios. Discrepancies occur in both directions. Sometimes the agent would choose an intervention that the patient would not want, and vice versa. Thus, this document is quite limited in the potential for disparity between patient and agent. One study found 32% had heard of or might consider executing a durable power agent, document, that is, not executing the agent. 30% of physicians might consider executing their patients in this society, unfortunately. Because of another study, though, which showed 68 to 82% of people may want to select a proxy following a detailed discussion, it is suggested that discussion with a physician may improve patient selection of the durable power document as a form of end-of-life planning. Another potential aspect of this document is the selection of treatment options. And you will see that there's 3 options listed here. You have the document in the back of your handout. So that a document can be designed to include options by which the patient may state preferences. However, in the state of Illinois at least, you can tell that legislators drew this up because the options are far from adequate. The options of life at all cost unless I'm in a coma, and the first option, which everyone chooses, life depending upon the risks and benefits of procedures and my state as judged by my agent, very nebulously stated, almost like a living will. So the options that are used in the Illinois form, at least, are rather inadequate. They need some work. A final weakness I'll say in this document is that people don't use it properly. You'll see the blank paragraph for preferences that can be stated there. This patient did not fill in anything in that blank paragraph. You can say, I don't want blood transfusions, or I don't want to ever be put on a respirator, or I don't want to be put on a feeding tube if I'm in a coma. Those kinds of things. No one ever, well, I shouldn't say no one. 1/3 of the patients we studied in our retirement community at the Presbyterian Home utilized something in that paragraph. So the documents are not really properly utilized, and if discussion with a physician was the context for filling out the document, perhaps people would put more information in that paragraph. To review then, at the bottom of page 2, the living will gives instructions designed to represent concerns of the patient. I would call it the living will, the patient's advance directive. The durable power is more of a legal mechanism, and I would consider it an attorney's advance directive. We then come to what's called the DNR, or do not resuscitate directive. And I would call this the physician's advance directive because it's the one I get most called about. Middle of the night, my patient gets admitted. Dr. Jaggard, first question from the resident, we need a code status. I said, well, do you have any signed document? No. Well, then it's full go until we find out what the story is. Now, a DNR, top middle of page 3 there, a DNR, on the other hand, provides a physician with a clearly defined directive phrase in medical terminology. Cardiorespiratory arrest is the condition, withhold CPR is the response. What the DNR lacks in ambiguity, it certainly makes up for in narrowness of focus. It does not provide direction in clinical situations that lead up to cardiorespiratory arrest. Now, other dilemmas are created. What do you do with the DNR patient who's going to surgery, where the process of induction of anesthesia carries some risk? Should the anesthesiologist's hands be tied in reversing any side effect of his treatment? No, I do not think so, and there's an excellent rationale that I have given a reference for on that issue. Secondly, another issue, should a patient who has a DNR directive already signed ever be put on a respirator? Well, 87% of our patients who had DNR orders thought that that was appropriate, and for example, for the purpose of treating respiratory insufficiency. Understanding the restriction of the DNR is very important and requires patient-physician interaction. Another issue is the importance of prognostic information. A lot of discussions going on about DNR policy right now, which is based upon prognostic information, and you will find rates ranging from 0 to 17% for the success in the elderly. And there's actually no good evidence that CPR is any less effective in the elderly because not enough adequately designed trials have been done. Another study I quoted shows that in the ICU, when a DNR order is written, it's associated with very high short-term mortality. So physicians and patients do tend to take into account their state of their health and whether or not to choose a DNR. 3% of elderly patients had previously discussed CPR with their physicians, though 87% thought a discussion should be routine, just like the living will, only even a lower percentage of actual discussion. Final comment on the weaknesses of the DNR is the poor understanding of technical medical language. In our study, only 7 of 16 patients who had a previously signed DNR could tell us that it applied only to the situation where their heart and breathing stopped, even after we showed them the document, because they didn't understand the term cardiopulmonary arrest. Others have found only a 7% comprehension of what CPR is. Recent developments, and then we'll move on. The Patient Self-Determination Act has already been mentioned. I don't think it'll accomplish its purposes. The reason is that it substitutes the relationship with the institution, the patient-institution relationship, for the physician-patient relationship. which is the more appropriate setting for advanced directives. Another development has been the medical directive. Now this one will really knock your socks off if you want to try to think about pre-end-of-life planning. 11 different interventions, 4 different clinical scenarios, 4 options for each choice. 44 choices to make with 4 options on each of those choices. And doctors Emmanuel and Emmanuel claim that they got their patients to do it in 15 minutes or less. That means 20 seconds per decision. To me, that's not informed consent. Okay. Values history, you could look at that. That's an interesting twist on the thing. Look more at the patient's overall worldview, and I think that from a Christian standpoint, a values history has some merit. Second part of my talk, which I left the minimal part for, let's look at the biblical perspectives. 3 questions I would pose. Is the concept of an advanced directive to limit extent of one's medical care ethically compatible with the faith tenets of a Christian physician or patient? 2, if so, what biblical principles should guide the Christian physician in utilizing advanced directives? And 3, what moral boundaries should limit end-of-life options for the Christian? Question 1, brief mention about how the sanctity of human life perhaps has been misapplied. Sanctity, like sacredness, means to be set apart. What are we set apart to? We're set apart to please God, to glorify God. Paul said, I can glorify God in my body, whether by life or by death. It is possible to glorify God in your death. Okay, Philippians 1:20. Now, the following 3 propositions are biblically derived and offer a framework for the compatibility of Christian faith and advanced directives. A, the frailty and brevity of life and the inevitability of death depicted in Scripture are themes which anticipate the notion of medical futility. And I've given you a whole list of Scripture references. Let me just read from the middle of the Job section some selected passages. Man born of woman is of few days and full of trouble. He springs up like a flower and withers away. Like a fleeting shadow, he does not endure. Man's days are determined. You have decreed the number of his months and have set limits he cannot exceed. Psalm 90, the length of our days is but 70 years, or 80 if we have the strength. Yet their span is but trouble and sorrow, for they quickly pass, and we fly away. As for man, his days are like grass. He flourishes like a flower of the field. The wind blows over it, and it is gone, and its place remembers it no more. All share a common destiny. Isaiah 40, all men are like grass, and their glory is like the flowers of the field. The grass withers, the flowers fall, because the breath of the Lord blows on them. Surely the people are grass. Jesus, Matthew 6, who of you by worrying can add a single hour to his life? James, why? You do not even know what will happen tomorrow. You are a mist that appears for a little while and then vanishes. Perhaps I should have been a mortician instead of a doctor. This obvious biblical fatalism or resignation to the reality of death is an important companion, and I would say a tension creator with the sanctity of life principles. Not that they're in conflict, but that they help us have a balanced view about the limits of human life. Sanctity in our worth, in our created image of God, brevity and frailty in the limits of our physical earthly existence, and opening our eyes to a greater reality, of course. By holding to both principles, we may affirm the value of human life without being forced into holding a position of perpetual mechanical life support. Proposition B, for the Christian, death is no longer a source of fear or dread because of the work of Christ in his death and resurrection. Death entered the world as part of God's curse on man's sin. As such, it is an enemy. It is not a friend, it is an enemy. And a source of fear and dread. However, for the Christian, the death and resurrection of our Lord have removed the sting and the victory of death. Death has no power over the believer, and in a spiritual sense, as Jesus said in John 11, he who believes in me will never die. It ushers the believer into the presence of God. Death will someday be the last enemy of God's people to be destroyed before Christ hands over his kingdom to the Father. In the light of the hope of the Christian faith, it is no surprise that, I find at least, Christian patients are among the most enthusiastic and motivated to execute advanced directives. The Christian physician may assist Christian patients as they go through a terminal illness by praying with them when appropriate and reminding them that though they walk through the valley of the shadow of death, they need fear no evil, for God is with them. Focusing on these assurances may help some patients in choosing a DNR status and alternative low-tech options such as hospice care. Proposition C, the Bible calls all people, not just Christians, to anticipate and prepare for the moment of death, for it is of great eschatological importance. References chosen include Hebrews 9:27. It is appointed unto us to die once. There's no reincarnation. And after that, we are evaluated. We are judged by God. Now, Pascal has an interesting little notion of diversions. And diversions of life are things which humans occupy themselves with, he said. As men are not able to fight against death, misery, ignorance, they have taken it into their heads, in order to be happy, not to think of them at all. We run carelessly to the precipice after we have put something before us to prevent us from seeing that precipice or that moment of our death. Sometimes high-tech medicine in the terminally ill may act as a Pascalian diversion. Many times it is erected just in front of the precipice because the patient or the family surrogate has dealt with impending death by a process of denial rather than resignation. Drop to the bottom of that page. Timely discussion of advanced directives might help a patient or a physician confront his mortality in a necessary and healthy way. Christians should consider the adjunctive role of such an encounter in assessing the spiritual health of the other. I have found patients who are believers who I did not know that before in the context of discussing advanced directives, and likewise, a Christian patient talking with a non-Christian physician about advanced directives may illuminate his understanding about the hope of the Christian faith. Well, second question, what biblical principles should be utilized in a Christian approach to advanced directives? One, the patient-physician relationship is foundational. They that are sick need a physician, not a government regulator, not a managed care executive, not a utilization review nurse or an admitting clerk or an attorney. The proper individual to guide the patient through advanced directives decisions is the physician. Only the physician knows the patient's medical situation and has the expertise to put the choices in proper context. Biblical principles which should be used would include compassion, looking to the interest of others. Jesus ministering to the woman with the chronic hemorrhage, she didn't want to confront the healer in a conversation. She wanted to just be healed silently and move about her business. He made her develop that relationship. He confronted her. There was power and healing in that confrontation. Professor Kilner, in his book Life on the Line, has talked about models for the patient-physician relationship, and the covenantal model has been mentioned several times before. Let me just say that in looking at that, I would say that the virtues of Christ are necessary in that covenant, and they would include grace and truth, John 1:14 in his first coming, and faithfulness and truth in his second coming. And I believe also, finally, the virtue of spirit of understanding, not only the physician understanding the patient, but the physician ensuring that the patient understands his medical care and choices such as advanced directives. Grace may be important in breaking some of the cynical attitudes toward the elderly that are developed in medical training. Grace may be needed to deal with difficult family members. Truth and understanding, as listed here, are also important. Finally, a couple of other comments about roles in the patient-physician relationship. The role of shepherding and the role of stewardship. Shepherding, interestingly, provides images of tenderness and care in Luke chapter 15, and a gatekeeper in John chapter 10. Advanced directives decisions need to be shepherded by the physician who has the knowledge to guide the patient. Stewardship is also spoken of in 1 Corinthians 4 as ministering mysteries of God. And to many patients, high-tech care is a mysterious thing, and the physician has a responsibility to make that mysterious subject more understandable. Question 3, what moral boundaries? Basically, the whole last page, page 11, is devoted to saying euthanasia is not acceptable. Direct killing is not something Christians should be involved in. But the point I want to make is that beyond that prophetic statement, we need to offer alternatives. And much like in the dilemmas raised by the issue of abortion, the church has developed responses such as abstinence counseling for teens as primary prevention, crisis pregnancy centers for counseling women who are facing abortion decisions as a secondary prevention to avoid abortion. The analogies in euthanasia would be we need to offer primary prevention. What is a primary prevention for getting into a situation like this? I think filling out an advance directive is a good first step, but it has to be done in the context of conversation with the physician. And secondary prevention, treating the terminally ill, hospice care is a very poorly utilized and misunderstood mechanism, but terminal pain management is a specialty in and of itself right now, and the National Hospice Association has come out with a statement in 1990 against assisted suicide and euthanasia. This, I believe, historically may be the first advance directive found in Psalm 71. It has an antecedent, when I am old and gray, and it has a consequential imperative, do not cast me away, and even more importantly, do not forsake, or in some translations, do not forget me. Now, I tried to talk about a DNR issue that was very, necessary to establish with one of my 95-year-old women, and she's like, oh, doctor, do whatever you think is right. What I really want to talk to you about is my bowels. Don't forget about my bowels. You may have questions about the resolution of the case we presented. And let me just briefly tell you that I did assume care because all the conditions that were met, that I had established, were met. And when the Institutional Ethics Committee saw the case and saw the patient, they were actually able to communicate somewhat with the patient. So I proceeded to try to establish some communication with her, which was quite variable, as you will see in many of the elderly patients on ventilators. They wax and wane in their alertness. On the second day that I was caring for her, she pulled out her NG tube, through which she was receiving procainamide, which was preventing her ventricular tachycardia. And it was in the middle of the night, and I told the resident, well, go ahead and put her on IV procainamide till I can come in and establish tomorrow what she might want. And the next day we came and we talked to her. 2 out of 3 times we raised the question in different ways. We were able to get a discernible response that was definite. And both times she said no, she did not want that tube back in, even though it meant saving her life if we would put it back in. So we left her off the procainamide. 48 hours later, she went into sustained ventricular tachycardia and expired peacefully with her family present. So I'll entertain any questions.
I think we do a great disservice, though, when we encourage people to sign advance directives without clearly explaining from the context from which they have arisen. It did not come out of the Christian community. In 1967, Louis Kuttner, in a conference here in Chicago, presented the First Living Will as the document to change the attitude of the American public. And by the way, this is Death with Dignity Week. I don't know if you knew that. And if you are a member of these organizations, Hemlock and Choices in Dying, it is your obligation to sign up all your friends and relatives on living wills. Choices in Dying has a campaign, and to further their movement. If you read the euthanasia books by Derek Humphrey and Burnell and the rest, they hold up the living will as the document which has furthered their cause more than anything else. And my concern is that we're not putting this in a proper context, that people must understand what the motivation was, of their presentation, what they have accomplished. Derek Humphrey has said we must go step by step, first with the living will, then with the durable power of attorney. Your side would call it the slippery slope. And we must understand that. And I'm concerned. I speak to many pastors who hand these out like they're handing out candy. And people are skipping the most important part of this whole process, thinking by signing this contract, which indeed it is, they don't have to talk to their family. They're skipping the whole process of discussion and the wonderful Bible presentations that you have provided, thinking that they're really relieving the family of decisions. But it's that decision-making which is the process through the journey of living, which I think we become too eager to eliminate.
I appreciate your comments. I couldn't agree more. I think the living will is really a very inadequate document. Some data that I'll leave up here for your perusal as we take questions. We did a conceptual analysis of patients' understanding. These interviews took over an hour each patient because they were so detailed. And we were trying to get at whether people who had already signed advance directives understood the essential concepts. And a 3 score would be perfect. They were able to tell us that off the top of their head. A 2 score would mean that they could tell us that after we asked them the question about the concept. And a 1 concept means that they only were able to state it once they saw the document in writing. And a 0 meant that even after seeing the document that they had signed, they could not explain the concept to us. And you'll find that, you know, the concepts at the top are understood well. Down at the bottom, the DNR order is very poorly understood by patients because it's a medically technical one, and therefore they do not understand that it only applies in a situation of cardiopulmonary arrest. Now, I think Christians need to have a voice because these advance directives are mushrooming. I think what we need to have a voice in is in formation of proper policy regarding their utilization to for our design of better documents, documents that would be less nebulous and would engender better communication between the patient and the physician.
I have 2 comments. The first is that as a physician, I've observed that the Patient Self-Determination Act has had very little real impact on anybody. What ends up happening when the patient comes to the hospital, some poor benighted clerk from the admissions office has to come and ask the patient about their advance directive. What inevitably happens is they say, no, I don't have an advance directive. The clerk checks off, no, no further discussion, end of incident. And so it has had no practical impact that I can see, which I'm somewhat gratified about. The other comment I wanted to make is that one thing that I try to do personally with patients when I'm discussing an advance directive is to get at their overall worldview, their religious position, as you mentioned, and to get an idea of whether they have a basis for what they're telling me they want in an overall ethical system. If they believe that basically nobody should have their life prolonged in situation X, and that's what they're asking, I feel comfortable with their advance directive. If they are ambiguous and say things like, I don't know what anybody else would want to do, but I just don't want to go through anything like that or put my family through that, or et cetera, I think it behooves us to ask the patient to, you know, think about it a little more and perhaps try to give them some kind of ethical framework. And that's difficult to do as physicians, but I think for us to hold these documents and act on them with the sense that we are being moral in doing so, we have to carry the discussion that one step further.
Right. I agree wholeheartedly with those comments.
Just a quick comment on the effect on the patient of presenting this. And my wife is not elderly, although sometimes she feels that. She has diabetic neuropathy. A couple years ago, when she developed osteomyelitis, the home health service came to start the IV antibiotics, and they said, and by the way, you know, we need to know about a living will. Now that came at a real vulnerable time and was a powerful push to someone who says, you know, oh, maybe this is the start of the end. Maybe I'm not worth being around.
Yeah, right. I'm sorry, go ahead. I think that because of the nebulousness of the living will and its potential for misuse and abuse, it should not be part of public policy to be used. I think more specific advance directives, and particularly having a surrogate agent. Hey, you know, if I'm incapacitated, I want my wife to be making the decisions, not a circuit court judge or the Cook County, whoever it is, public guardian.
And I would have to say that as I've listened to this discussion, I think I could speak for my also elderly friends as saying that our concerns are much more the physicians who do not share our views of it's not worth it to a Christian to extend the dying process. I find my friends are much more concerned about that than they are about euthanasia because of their experiences and their experiences with their friends. Because my colleague, physicians, have the concept that we must save life at all costs. Death is the ultimate enemy. I submit to you that death is not the ultimate enemy to the Christian.
I agree, the ultimate enemy is the evil one. Death happens to be the last one chronologically to be destroyed. But we do face it. For the Christian, there's great victory, but for the unbeliever, there is great fear. And we have to wrestle with that. How do we, as those who do have something to offer in terms of hope as Christians, then as professionals also relate to patients who cannot understand that?